Hello everyone. Today Dr. Moran and I discuss sepsis, prepared to revisit what the SIRS criteria is and how it relates to sepsis. We'll discuss the Pitstop trial and how it can be beneficial in the prehospital setting to give antibiotics. We'll discuss high-risk populations that are prone to sepsis and worse outcomes, and we'll discuss the ideal vasopressor and why septic shock is actually quite rare in the prehospital setting. We'll discuss that and much more. We hope you enjoy. You wear a nice shirt today, too. Nice blouse.
Yeah, that's right. I didn't wear a t-shirt. I was stupid.
No, I was telling you, we're making you famous now on Instagram and YouTube and everything. So people know, people appreciate this.
Yeah.
So today's sepsis.
Yeah.
And it's kind of timely because I'm sure everybody you're seeing right now in the emerge is sick with some sort of infection.
Well, it's that time of year, yeah. Yeah, definitely. Lots of flu. There's always COVID circulating, and if there's lots of flu, it sort of leads to a lot of pneumonias and things like that. So you do see a lot.
We'll delve into all that. Like, just a rough estimate. How many patients do you see roughly in a shift you think are possibly septic?
So I guess like true sepsis is not actually super common. So I wouldn't even say I see as many as one per shift. People who would sort of meet the SIRS criteria, I don't know, I'll talk a bit about that. There's lots of people who would meet the SIRS criteria, but of those ones who are actually septic would be actually a very, very small number.
I guess it's even smaller than septic shock.
Oh yeah, that's actually very rare in the grand scheme of things.
I remember you telling me, correct me if I'm wrong, that it's funny in paramedic curriculum, we have to identify the different shock states by clinical manifestations, and you're like, you know how hard that is without diagnostic tests in the real world?
Yes.
Yeah, so it's kind of funny.
Mm-hmm.
Can you give us a brief overview of what is sepsis then?
Well, I mean, the sort of the general thought behind sepsis is that your immune response to a normal infectious process is excessive. Again, normally you get sick, you get a fever, you mount a white count, you fight off the infection and you carry on. But in certain circumstances, your immune system is, again, sort of overly turned on, so that you're releasing an excessive amount of cytokines and other types of inflammatory markers that then cause you to have vasodilation, which would seem to be totally counterintuitive in an infectious process. But this excessive response leads you to have these, again, vasodilation with a drop in your blood pressure. You can have altered mental status. And this is, again, it's all due to your body's own inflammatory response to the infection.
Because that's key, because we always talk about how, I have an immune system, I'll be fine, but it's actually your immune system that's going to kill you.
Right. It's not a lack of your immune system. And I think if you sort of flip it around the other way, this is why we get so careful with people who are cancer patients who might be neutropenic, is because they don't mount a significant immune response. They can look completely normal and actually be very sick. So that's kind of the other end of the spectrum, where you have these very well-looking people who may be very, very sick with an infection. And again, they don't look sick until the wheels completely fall off.
Why is that?
Just because if their neutrophil count's really low, they don't mount the immune response. So they don't have any release of these immune modulators. And so other than having a fever, they may have nothing. So their ability to actually effectively fight off, remember I was saying like sepsis is sort of an excessive release of all of these mediators. They get really none of the release of the mediators. So that happy medium where your body's able to fight off the infection but not get really, really sick from it, they don't even get to that point. So the bacteria are busy doing their thing, you're not mounting an immune response, and you're perfectly fine until the critical mass of bacteria are there, and then you just can go completely off the cliff.
That's a good operational point, because We did so many patients that are like, okay, I'm a cancer patient and receiving treatment. And they said, as soon as I get a fever, call 911 and go to the hospital.
Yes.
And like, that's key. It's like, you can decompensate quick.
Yeah. So if that person comes in, they have a fever and their white count is normal, they're fine. They can mount an immune response just like anybody else would. But if they have very, very low white blood cells, then they don't have that ability to.
I assume it could be any like pathogen that could lead to these immunocompromised patients to decompensate.
Absolutely. So, whereas in people who are immunocompetent, you're going to be more likely to get sick from encapsulated organisms like pneumococcal pneumonia or meningococcal pneumonia or meningitis, that sort of thing. In the immunocompromised people, it can be anything can really push them over.
The even common cold.
Yeah.
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 And you mentioned like influenza. Is that typically what you're seeing in the vast majority of people?
It's starting to ramp up right now. Yeah. Yeah. It's, we're early in the season, so we haven't really seen the spike of it. It usually sort of comes in around December or so, but we're going to be starting to see a lot of that coming up for sure.
And you mentioned cancer patients. Is there any other population that's high risk?
So anybody who's on any sort of immunosuppressing drugs, which would be the exact same process. So people who are on prednisone on a daily basis, people who, we don't, in this area, we don't see a lot of transplant people, but the people who are, have had transplants are always on an immunosuppressant. And then people with other diseases, such as rheumatoid arthritis, lupus, the Crohn's disease, even people with psoriasis, they can be on these immunosuppressing medications. And so you have to be careful with those because they'll be very similar to the cancer patient with their response.
It's really good to know because I can remember so many of those patients that we've seen and they seem fine, just a fever.
Yeah, so you have to be, for me as an emergency physician, I have to be very careful with those to do enough of a workup to ensure that they don't have some sort of underlying illness that would require more treatment because they may not look like somebody who would have those diseases and were not on these medications.
So what would you look for specifically?
So really it sort of comes down to, a lot of their labs, like what are their white counts? What's their white count like? You would often do investigations that you would not normally do. So you may do a chest x-ray in the absence of a cough. You may do a urinalysis in the absence of dysuria. So looking for sources of an infection where they're not manifesting the normal symptoms that would go along with it.
What's the major sites of infection?
So the major sites are sort of, it's going to be respiratory, urine, and usually skin. One of the important things to do is have a look to make sure that there's not like an ulcer somewhere or something on the person's foot, or something that they've been sort of considering to be a rash, but it's in fact not a rash, it's actually a cellulitis. So you have to sort of go on a little bit of a hunt.
How many walking pneumonias do you think you see?
So they estimate with the walking pneumonia as being about 7% of pneumonias. The big difference, I think, between what's called a walking pneumonia and a regular lobar pneumonia is the way that they present. So traditionally they call them walking pneumonias because they don't tend to get as sick, and usually don't end up diagnosing it until a little bit later because they've just been sort of looking like a viral illness for a while. And typically we will sort of aim, if someone comes in with fever and a cough and they've had the symptoms for 5 days, we'll typically do a chest x-ray. But if a person sort of is at home and they're kind of deciding to wait this out and they get to sort of day 10 and they're still coughing and have a fever, they come in, those are a higher likelihood of them being sort of one of these atypical pneumonias, like a mycoplasma pneumonia or something like that. You've probably been hearing a lot about this rise in number of walking pneumonias that are going on right now, but in fact, they found that the number of atypical pneumonias went down during COVID, probably because we were all isolating ourselves, and they're actually sort of coming back up to what the baseline was before COVID ever came in, but it's sort of manifesting itself as this sort of increase in cases, and so you'll hear a lot of that talking about there's this huge increase in cases, but it's probably not. It's probably just us getting back to baseline again.
Interesting.
Mhm.
COVID pneumonia, then. How common is that now?
Not that common.
That's good.
Yeah. Tend to see it more in the elderly. But it's relatively infrequent. And we have despite the fact not everybody's, of course, been immunized against it, there's a larger penetration of immunocompetent people who've had their shots against COVID, and so they are able to effectively fight off the infection without sort of getting to that point. It's actually it's been quite a while since I've even seen a COVID pneumonia, so that's falling.
So in comparison to 3 years ago, when you were probably seeing multiple shots,
Lots of it, yeah. Be admitting a lot of people with COVID pneumonia because they're becoming hypoxic and couldn't have to come in. Yeah.
So you mentioned the SIRS criteria.
Mm-hmm.
What's that?
So they've been around for a long time. They're a set of criteria that are supposed to heighten your awareness that maybe a person who can progress on to sepsis. So it includes 4 things. It includes your heart rate, your blood pressure, your temperature, and your white blood cell count. It is unfortunately one of those things very sensitive, and the specificity is terrible. Your likelihood of actually progressing on to sepsis, if you meet the criteria, which is 2 or more of those 4 things are positive, is actually extremely low. So, for example, having one of them is the temperature, a temp of greater than 38 or less than 36, and then the second is a heart rate of greater than 90. So, you think of the number of people you see with a fever with a heart rate of 95 to 100 is almost everybody. And as you know, most, like the vast majority of those are just going to be fine. So relying upon those criteria alone to determine if somebody's septic is not really reliable at all. It's really just more to think about it. It does tend to trigger in an emergency department if you meet those criteria, that you'll end up sending blood cultures off to see whether or not there is evidence of infection. Again, the vast majority of those are negative, but it's just a kind of a fallback way of ensuring that we don't miss somebody with a significant infection who looks well. But the criteria themselves are not, in and of themselves, super useful for determining who's septic and who's not.
Because, like you said, like if someone has a fever, they're probably going to be tachycardic.
Yeah.
So,
well, even if you're responding as a paramedic to a call, the likelihood of their heart rate being greater than 90 just because you showed up is going to be high. So, yes, you're going to have a higher index of suspicion if they're like low blood pressure and tachycardic and fever, but it's, again, you're not, even the white blood cell count cutoff that they use for the SIRS criteria is 12. Well, I've seen people who are not sick at all with a white blood cell count of 12. So they're not really accurate being able to determine anything.
is the SOFA criteria, is that still used?
Not really. So they really was more of a critical care scoring system that was part of QSOFA came out as part of the Surviving Sepsis campaign, which then went through a wholesale rejection by the medical community because it was found that it was very much being driven by drug companies that sponsored it. So they're not typically used. No.
That's good to know.
Mm-hmm.
What about the news criteria?
Yeah, I don't know much about the news criteria, to be perfectly honest.
Neither.
So,
yeah, I just know because there's like certain scores that they use around the world, and especially from pre-hospital and hospital, it matters if what we tell the emerg staff, like even if I say I think the baby's septic, is that helpful for me?
Yeah, I think so. I think at least triggers the nursing staff to look that way. and may also trigger them to start ordering lab work appropriately prior to the physician necessarily coming in to see them. So it kind of helps to move things along. The other part of that too is if there's concern about sepsis, and time to antibiotics is important in those situations, that it may sort of flag for the staff that maybe this needs to be seen by a physician earlier.
You find like the human factors in that, because how many times have we given reports and it says flag sepsis, there's false positives and they just ignore them?
Yeah, absolutely. So it is difficult, and of course there's going to be barriers to that, but I still think it's worth the paramedics informing them to, because if they are concerned, it should at least be brought to the attention of the staff there. Yeah.
What's worse, fever or hypothermic in sepsis?
So, it's a difficult question because so I guess in theory hypothermia would be worse. The difficulty then comes into play if you find somebody who's hypothermic is how do you know if that's because of sepsis or because they're hypothermic or because they're Addisonian or if they're because there's so many different things that can do it. So it makes it more difficult to elucidate the cause. Like a fever is a fever, but a temp at 35 can be
Lots of things.
Yeah, it could be environmental. It can be like there's lots of different things. And yes, you can get that with high temperature as well, but often there are situational factors which would make you think this is more likely like a decompensated heat stroke as opposed to a fever. So it's difficult with the low ones, but in theory, yes, a low temperature would be a more concerning issue with sepsis. Because typically septic patients are very vasodilated, and so they're shunting all blood flow to the skin, and theoretically your temperature should be high. But if things are failing that much and their temperature is low, it can be a pretty significant situation.
Is there a benefit to a fever? This will be a two-part question.
So yes, and I think it depends on what you read, but in the end, that resetting of the body's core temperature to help to activate your own immune system is actually beneficial, and that's why it's part of our immune response. It's not otherwise it would have sort of phased itself out through Darwinism years ago. We wouldn't be having fevers that way if it wasn't a benefit. So it is useful. Yeah.
Because if I had a man cold and I went to emerge and I was 38.4, would you be concerned?
No.
Yeah, even though I'm uncomfortable and shaking?
Yes.
So my next question is, how come we don't have an antipyretic medical directive for this whole setting?
Well, no, and that's been it's an ongoing question, and I think that so the first and probably most important is recognizing what the pre-hospital role is that fever is not an emergency. Not only is it not an emergency, but as we just said, it can be actually a beneficial thing. So yes, people are uncomfortable with fevers and they can have a headache and feel sort of unwell, but treating their fever alone is not doing anything to manage their underlying condition. Yes, you could say it's sort of symptom relief, but it's in the end, it's really debatable as to whether or not treating fever is of any benefit at all. So it's I think the value of things like acetaminophen and ibuprofen in the paramedic bag of medications is definitely from the analgesia and not from fever management. And the reality is too, if you're called to a patient who's had a febrile seizure, the number one, you probably don't want to give them something orally right after they've had a seizure anyway, and number two is really the likelihood of them having a second febrile seizure in the same illness is actually extraordinarily low. So trying to get an antipyretic on board is probably not beneficial at all at that point.
And correct me if I'm wrong, because I remember looking this up. They've tested this a bunch, but if you give someone that had a febrile seizure antipyretics, it doesn't reduce the chance of them having another febrile seizure.
No, it does not. It's I think it's more makes the family feel better that they're doing something proactive as opposed to it actually having any evidence that it makes any difference.
So that helps to know when I go to St. Margaret's and I get reprimanded for not giving the kid antipyretics.
Exactly.
Yeah. So that's an evidence-based solution.
Yes.
Is there something like if you have a temperature too high, would you be like, maybe we should lower that? Like if they're in the 40, 41 range? No.
No. The height of the fever in young children has a bit of a correlation with more severe illness, but like reducing that temperature from there doesn't change the trajectory of the person's illness at all. And although family members can be very, very concerned about temperatures of 40 or 41, I will always tell them that really that's just the body's inflammatory response. It does not indicate that the person is sicker or that there's a higher risk of them having something bad. And again, there's that, like I said, there's a little bit of a difference with that with little kids, but in sort of your typical adult, there's really no difference between if the temp's 38.5 versus 40.5.
That's good to know.
Yeah.
The inflammatory response in blood pressure.
Mm-hmm.
Why do they become hypertensive?
Well, again, there's a lot of things contributing to it, but it really has to do with sort of cytokines and interleukins, which are then affecting the permeability of the blood vessel walls, and so you end up having a lot of extravascular leak, and they also do develop some vasodilatation in addition to that extravascular leak. So not only are you losing fluid out of your bloodstream, but your blood vessels are also dilating to a certain degree as well. So the combination of those two things then leads to becoming hypotensive. And that's also why sort of the management is sort of stepwise with those, is that you administer fluid, and if there's not a significant response to the fluid, then we would consider also using vasopressors. So it's whereas again in trauma, it's all about fluid. Like you're not going to be starting to try to use vasopressors on somebody who's just lost intravascular volume. You can't squeeze an empty pipe and make the pressure go up. But in sepsis, it's because it's a combination of those two things. You can actually treat both, but fluids are always your first go-to.
So, of course, our medical directive is 20 mils per kilo for a patient.
Yeah.
Is the surviving sepsis campaign still 30 mils per kilo?
No. So the surviving sepsis has really gone by the wayside, and something. But I think it does make sense that if you give a 20 mil per kilo bolus and there's not a response, would be so. If I was treating somebody like that, I would give the bolus. If they don't respond, I would probably repeat the bolus. And if there's still not a response, then looking at going to pressors. Or I may even look at going to pressors during the second bolus. But I think 20 per kilo is still a very reasonable amount to give. Because again, in the average person, that's really like in an average size. We know a lot of people on average size, that's still like 1.5 liters. And I would really be thinking if I'm giving somebody 2 liters of fluids and they're not responding to it, I'm going to be moving to pressors probably.
So I've got points in there. Because how would you tell someone's fluid responsive?
Well, it's all by vital signs.
Yeah.
So you're looking at if their heart rate is responding or their blood pressure is responding or both, then that's a fluid response.
What MAP should we titrate to for sepsis, for fluids and vasopressors?
Well, it's difficult. So I will say that the vasopressors that you have available to you as paramedics are not good for sepsis. So I honestly would probably not even consider going to dopamine in those settings, because you would need an enormously high level of dopamine to even move the MAP on those at all. And even then, you may not get anywhere with it. And the flip side of that is you're also going to induce an increase in the tachycardia, which they've already probably got pretty good tachycardia going on. So, so I honestly, I'd be very hesitant to sort of say, here's a map that you should be looking for specifically in those cases, because maps are usually geared more for management of inotrope support as opposed to fluid bolus support. They all need fluid boluses. You want to be aggressive with their fluids. So And again, I've sort of hesitant to throw a number out there because I don't want people to sort of get hung up on that.
Well, that's good because it's nuanced. It's so nuanced.
Yeah.
And correct me if I'm wrong, they removed dopamine for those reasons because it can cause proarrhythmic events.
Yeah, but it's also because it's not that effective in managing it. It's so the big thing with sepsis is because it's all about vasodilation, that you're really looking for vasoconstriction, whereas dopamine has both alpha and beta effect, but is also not a strong alpha agonist, and so it's not super useful in these situations.
We should be clear that just sepsis, like it has benefits in cardiology.
Oh, absolutely, and that's again that each type of shock has a different pathophysiology, and so trying to match the drug to the pathophysiology is really the key to all of this. And in this particular scenario with sepsis, the one that they're most likely going to respond to is norepinephrine, which is very much an alpha agonist, but you'd have no other real use for norepi, and so that's why it's not carried pre-hospitally. Plus, also, it is an extremely potent vasoconstrictor, and so requires very careful monitoring when you're using it. And often you need to have central monitoring, and so it's not something that's really I think viable for use pre-hospitally.
Because I know like some paramedics are like, I don't have anything that I can benefit these patients in the pre-hospital setting. It's like, I think we're doing a lot more than we realize, because sometimes it's better not to do something and wait for them to get the right pressure at the hospital.
Yeah, and you can't. You're giving them fluid, and fluid's the most important thing to start with.
And recognition.
Yeah.
Is there any difference between colloids and crystalloids for sepsis?
No. Well, no. Yeah. So it is. Why I was sort of a little hesitant on that is because, as I mentioned, you do get a lot of shifting of fluids out of the blood vessels, and so crystalloids you tend to lose some of it into the periphery. But so theoretically, if you gave more colloid, it would sting intravascularly, but there's not actually a lot of evidence to support that. And so really crystalloids plus vasopressors are the management on it.
Because is there a point where you could give too much fluids? Because you kind of mentioned it already, that we get cause more leakage for fully excess.
Yeah. I mean, there's having said that, if you're sort of 5 liters of fluid in, that's probably not going to be great, because they are shifting fluids. They're putting it into their lungs as well. They could go into pulmonary edema, but you're never going to get to that level pre-hospitally. Again, I wouldn't even really probably consider using a vasopressor until I got 2 liters of fluid in already, and so that the likelihood of you managing to get that much fluid in a pre-hospital environment is very, very low, and the likelihood of you pushing somebody into heart failure because you've given 2 liters is actually very, very low. So even in elderly people, the initial management is this aggressive fluid management.
What if they have like renal failure or congestive heart failure and they're septic? Are we worried about fluid?
You're still going to be fluid's still going to be your primary consideration. If we have to manage heart failure by doing any sort of invasive or non-invasive respiratory management, that's okay. It's sort of considered that that's going to be a possible risk, but the risk benefit of not giving fluid is very much in favor of the giving of the fluid.
Have you ever seen that? You start bolusing them and subsequently they start developing acute cardiogenic pulmonary.
Usually not emerge.
Yeah.
Like if it's going to happen, like that fluid shifting does not happen immediately. It's a delayed response, and so they're probably going to be in the hospital or in the ICU if they start to develop that. Yeah.
So you'd be happy if, like, I came in and I said, I think there's septic. We've given 2 liters.
Yeah.
And then you're like, okay, so I might have to move on to something else.
Yeah. So, and probably jumping ahead with this to another point, but that's sort of the point of the Pitstop trial that's going on right now. So it's looking at aggressive versus normal fluid management and pre-hospital antibiotics versus non, and whether or not they have an outcome benefit or not. So, so if somebody came in and told me that I'd given 2 liters of fluid, there's obviously enough equipoise to encourage doing that sort of therapy in a study environment, that I would be very supportive of that.
What antibiotics are they giving in that study?
Ceftriaxone.
So what does that do?
So ceftriaxone is a broad spectrum cephalosporin. It's a third generation cephalosporin. And why the broad spectrum is because a lot of the times in sepsis, you don't know what the source of the infection is. You can tailor antibiotic therapy to the source once you have a sort of a good hold of the source. And that often is done with a combination of your investigations plus your blood cultures. With blood cultures, they'll then run, if there's a bacteria that grows, it will then sort of see what it's sensitive to antibiotic-wise. And then once you have that, you can tailor your antibiotic. But prior to that, you want to make sure that you're covering for whatever might be the source of infection. And that's why sort of going with the kind of big gun broad spectrum antibiotic is appropriate. But the flip side of that is that you don't want to be using it when the person is not manifesting signs of sepsis because of the risk of resistance. Any sort of broad spectrum antibiotic has the risk of developing resistance to it, which is sort of what we've seen with older ones like Cipro, which is fairly broad spectrum, and everybody was being given Cipro for UTIs, et cetera, and now there's high resistance to Cipro. So trying to keep these broad spectrum antibiotics to a limited window of people that we treat with it.
Unintended consequence, I guess. Right?
Yeah, exactly.
Would you be supportive of all paramedics carry that antibiotic?
Well, I think that's the point of the study. I mean, I think if the study is positive, it shows that there is clinical benefit to giving it, then absolutely. But I think that's still we're still waiting on the science to see whether or not that is supported or not.
Because, correct me if I'm wrong, every delay, like hour delay of antibiotics, leads to increased mortality in these patients.
Yeah, so there is sort of a trend towards that, and the goal is for, as an emerge physician, is to try to administer antibiotics within the first hour of them arriving. And again, we're looking at whether or not, which would then intuitively make you think that if we gave it even earlier, if we gave them as soon as the paramedics saw them, that would even increase that benefit. But again, the reality is we don't know. And there's a lot of things, as you're aware, that we do in medicine where you sort of extrapolate data to other things where you think it makes sense that it will work, and then you do the study and it in fact doesn't. So I think that's why we need to sort of see what the science shows before we kind of put the cart before the horse and say that, yes, I think that this is going to work and therefore we'll do it.
How long's the study now?
I actually think they're pretty close to having their enrollment done because it's actually been running for several years. So I can't remember exactly how close they are to their final numbers, but I think they're actually very, very close to being finished with their enrollment. So hopefully we'll know within the next 18 months or so what the results are.
Because I know antibiotics was concerned about how do we store this, because a lot of them have like low shelf life, right?
Yes. Yeah.
So why is that one easy to store and use?
Honestly, I don't know. I don't know how it's ceftriaxone. I don't know how it's stored. I know it doesn't have to be refrigerated. And the advantage of it over some of the other antibiotics is because its dosing is fairly straightforward. It's typically a gram for pretty much everybody, even weight-based. It ends up being a gram. We do it sometimes in serious infections. We give 2 grams, but I mean, a gram is probably coverage for everybody. It can be given IV, it can be given IM. It hurts like heck if you give it IM, but you can give it IM. So the advantages are it pretty much covers all the infections you would ever want to treat, and it's easily given, and it's not refrigerated. But as far as how long it lasts, I have no idea. So I don't know what the turnover as far as how frequently you'd have to replace the drug would be.
But I guess that signifies that the vast majority of septic patients are bacterial in nature, right?
Yeah, so it's rare to get septic from a virus. They don't usually manifest that type of immune response. So usually if you were starting to manifest some signs of sepsis because all viral infections are self-limited, you'll usually end up sort of fighting off the virus before you ever got to that stage. So yes, people do get admitted to the hospital for possible sepsis and they end up being culture negative. But usually in those scenarios, it's then felt that they were, that they may have had a virus, it may have been something entirely different. The vast majority would be bacterial. Yeah.
Because that's like the 1918 Spanish flu.
Mm-hmm.
It was so deadly because it led to secondary bacterial pneumonia.
Right. And that's really the risk of, the vast majority of bacterial pneumonias are secondary to viruses. So if there's enough of an inflammatory response in the lungs, it can predispose you to developing pneumonia just from aspiration of your own airway flora. So that's one of the big risks with influenza is that it can, just the regular circulating influenza, is that it can predispose you to pneumonia.
I guess the best advice you can give as a physician is get your vaccines for the influenza, right?
I've already had mine.
Yeah, me too.
Yeah.
Is it a good match this year?
From what I understand, yes.
So
I think it's two of the three. Two of the three circulating strains are covered by the current one. So yeah, good to know. Mm-hmm.
So blood sugars in sepsis. What typically happens with their blood sugars?
Yeah, so it can go both ways. In patients who are diabetic, type 2, who have been any sort of stress to their system, it can cause their sugars to rise. The reverse can happen as well if you're actually going into septic shock and you're sort of, it would just considered to be consumptive because your immune system is so overactive that you can actually drop your sugars. You're more likely to see high sugars in the setting of people with infection.
Because the compensatory response to the hormones?
Yes. Yeah, exactly.
Would it be beneficial, obviously, to treat them with dextrose, D10 or D50 if they're hypoglycemic in sepsis?
Yes. Yeah. So if they're hypoglycemic, just like with any other hypoglycemic incident, you're to be able to maintain all of your cellular metabolism, you need glucose going in. So if they're low, absolutely. If they're high, yeah, you're basically you're treating them with fluids already anyway. And that was, again, one of those things that was originally part of the surviving sepsis criteria is like tight glucose control. That's actually been shown to not be as important as was previously thought. So people used to be put on insulin drips and things like that to try to normalize. That's actually probably not beneficial.
Because I've heard this counter arguments like, why would I treat the sepsis or treat the hypoglycemia and fuel it with more sugar? You're like, well, they're going to die without the sugar.
Yeah, I mean, you still need to be able to have that immune response. You may be overactive, but the way to slow down the immune response is not by stopping your cellular metabolism, because there's so many things in your body that rely upon that beyond your inflammatory cells, like your waste cells. So,
what's the typical value for blood sugar in a non-diabetic patient? We were like, this maybe meets the criteria for SIRS. Because we were taught 7.7. I don't know actually.
Well, I mean, it's like your sugar is not actually a SIRS criteria.
Yeah.
So I would be very hesitant to use it as a marker.
Because it could be elevated based on meat pressure.
There's a lot of people whose sugars are elevated anyway. It's really difficult to use that as any sort of accurate marker.
What about entitle? If their entitle's low, do you think that's sensitive and specific?
No. There's not good evidence to support certain numbers with what your entitle is. So, and depending upon what state of sepsis you're in, it really doesn't correlate well at all.
Pneumonias.
Yeah.
How should paramedics treat pneumonias?
The same as you would with any other infection. Like if they're hypoxic, you treat their hypoxia, and otherwise you treat with fluids if they need them. And that's really all that you can do, because the only other therapy above and beyond that is antibiotic, but you can't diagnose pneumonia without a chest X-ray. And so it's just supportive management otherwise.
What about Ventolin?
So there's virtually no evidence that Ventolin treats or helps to treat pneumonia. Now, having said that, there are some people who do develop some bronchospasm in the setting of respiratory infections, so that small cohort of people, if they have wheeze, often will respond to Ventolin. But if there's no wheeze there, then puffers, even inhaled steroids that people get sent home on, probably don't do anything.
So you're not recommending Paramedic's patch for dexamethasone for pneumonia?
No.
Yeah.
No.
Why does a pneumonia actually occur, though?
So again, they're almost all secondary to viral infections. So you develop this viral inflammatory response in your lungs, and sort of as a result of the increased secretions and deposits in your airway, the normal cilia activity in your down in the small airways, being able to clear out debris and phlegm, etc., is somewhat inhibited. And every night when you go to sleep, you do actually microaspirate a lot of the bacteria in your upper airway. So under normal circumstances, your cellular responses and your cilia are able to clear all that stuff out. But if in the setting of a viral infection, that's inhibited, and so those bacteria can actually sort of set up shop down there.
So where we naturally cough more when we're sleeping?
Yes.
Yeah, that makes sense.
Yeah.
So then it leads to these areas of consolidation, and obviously that can impair gas exchange. Right?
Right.
Have you ever seen bilateral pneumonia?
Yes.
Besides aspiration?
Not infrequently. Yeah.
Oh, is it?
Yeah. Yeah. It's not that uncommon. Yeah. Multilobar pneumonia, things like that. Yeah.
Is it common in pediatrics or more like elderly immunocompromised adults?
No, I've actually seen it in immunocompetent adults, not infrequently as well. So it really can happen in anybody.
How would it differ then for pediatrics if you're suspecting sepsis in them in comparison to adults?
Really not a lot different. So young kids, like babies under the age of 2 months, it's a whole different scenario. But typically, once a baby becomes immunocompetent, really sort of a sick 6-month-old is no different than a sick 6-year-old. They will manifest the same type of immune response, and to that point, it's actually not that much different from seeing a sick 30-year-old. They'll if they're going to develop sepsis, they'll have the same sort of septic response, obviously within the parameters of their vital signs, but they will develop that same type of response to an infection. So it's really not that much different.
Are the pathogens a little different?
Yeah, so not as much anymore. With sort of routine vaccinations, but there are some differences as far as what people are exposed to, like the typical pathogens that cause pneumonia in somebody who's over the age of 60 are going to be different from others. So that's gonna sort of when we treat pneumonia based on a positive chest X-ray finding, pretty much everybody gets amoxicillin as their first line, unless you have some of these other criteria, like you're older, which will go more broad spectrum of them. Yeah.
I guess RSV is a problematic component to the very young pediatric patients.
Yeah. And we're getting into that season again. It sort of tends to be around the same season as influenza, unfortunately. But the big issue with RSV is that it causes a type of reactive airways that doesn't respond to bronchodilators. So they can be very wheezy. You can give them all the Ventolin in the world and they don't get better. Now, the management of RSV is supportive. So if they need to come into hospital and be on oxygen, that's what they do, but there's not really much other treatment for it.
Yeah, because if they're not responding to supportive treatment, what happens at that point?
Well, I mean, in the absolute worst case scenario is that sometimes they end up getting intubated. But again, it's ultimately that's still just supporting the breathing until they get better. So you're just waiting for them to fight off the infection themselves.
I can only imagine what you saw 2 years ago with the RSV wave, and just seeing the sickest pediatric patients I've seen with excessive muscle, and I was like, yeah, it was insane.
Yeah, and as a result of that, every time winter comes in, most hospitals will sort of set up a pediatric surge plan in case it happens again. There were so many kids that were admitted to the hospital on oxygen because of that.
So if we could recommend a couple things for paramedics to do tomorrow for sepsis, if you had a magic wand to make it the best system possible, what would you like to see?
Well, again, because most of sepsis care is supportive, I think paramedics already have the tools in their hands to be able to start the treatment appropriately. So I think it's, recognizing it, giving fluids, and advising the receiving staff that you have a person that you feel has a high likelihood of being septic. The whole part of the antibiotic remains to be seen, but the reality is, for me, if I was treating somebody like that, I would be doing the same thing. The exception being that I have access to sort of those potent inotropes if they are going really downhill, but that's few and far between. And so I think the paramedics do have access to all the tools that they need.
Would you recommend paramedics like patching into the hospital? Like, hey, I have a 7-year-old suspected septic patient.
I think it's debatable. There are places where they have actually enabled that. There was that they were doing, I don't know if they still do, but I know in Hamilton they were doing sepsis alerts. I think it would really have to be a discussion between the receiving hospitals and the services as to whether or not they felt that would be something beneficial or not. Because if the receiving hospital is not prepared to do anything differently if they receive a sepsis alert, then it's ultimately it's using the paramedic's valuable time to have to call in to tell them they've got this, and when they're not going to change their approach to it at all.
What are differentials? So like if I come in and say, I think they're septic, then you do blood work diagnostics. Mm-hmm. What's common differentials you would see?
Well, I think it's not, so sepsis is more of it's a response to a condition. So the sepsis in and of itself, if you're looking at sort of a differential for sort of low blood pressure, increased heart rate, they can be volume depleted, they could be bleeding, they could, there's other things that can do that. They can be overdoses. So the differential for something like that's actually fairly broad. So I think really it's more in the situation of recognizing that somebody with an infection who you think might be at risk for sepsis or maybe manifesting some symptoms of sepsis. But again, you do have to consider, particularly in the elevated temperature with abnormal vitals, that there are certain types of overdoses that can do that too. So you have to consider those as well.
I don't know if this is a one-off, because I always remember this. I thought we had a septic patient. I went back to check on them later, and the staff just laughed at me. They're like, they had pancreatitis. And I'm like, oh, stupid me.
Well, so they shouldn't be febrile. There are in the list of many things that can cause pancreatitis, there are a couple of viruses that are actually in the list. Most people with pancreatitis won't show up febrile. Yeah. But they will. They because pancreatitis does sort of act kind of like a burn. You can develop hypotension and whatnot because of that too.
Mm-hmm. Any last thoughts that you want to tell
them? No, I think it's just having a high index of suspicion. But I think ultimately just to sort of follow your own clinical gestalt. Like you're trying to support the patient. So if they're hypoxic, you treat that. If they're tachy or hypotensive, you treat that, and you have the tools and the ability to do that. So I think the paramedics are well equipped to be able to identify and manage these.
Is IMPACT program doing anything with sepsis right now?
No. So I mean, because ultimately the IMPACT is really designed to find who you can leave home. Sepsis clearly is not somebody you should be leaving at home. So IMPACT is really not geared towards doing that.
Perfect. Thank you so much.